think, again, in benefit of time, I will just respond to one of the questions which was sent to me, and then we will move on to talk about the process around death. Obviously, we are not going to talk about the caring at one's dying because we have already had enough discussions about that. But this was a discussion sent to me. Can we prescribe opioids towards the end of life? And some of people of my age who were in healthcare back in 2003, 2004, 2005, there was a huge debate. Is it like allowed to prescribe morphine for the patients? Not just for cancer, but for anything, because of its intoxicating nature. And I remember having huge discussions in various forums where we've talked about how do we get around it. I thought we had solved the system, but again, I will not talk about the fiqhi masail because we know that the treatment given to resolve symptoms is allowed. But the question is still asked that so does the morphine not shorten your life and kill you, and that's why it should not be allowed? So the answer, I will just quickly go 2-3 slides for this answer. We need to understand why do we prescribe opioids. And again, I don't want to bore everybody who is non-clinical. This is the role of opioids. And the systems are written. They are chemicals or which opiates, we use it interchangeably. But let's talk about morphine because that's the question asked. They work by working on particular receptors. They are in central nervous system and they are peripheral nervous system. So they work good on pain. Now, a question was asked that how is it intoxicating? So just look at some pictures for me, if you are okay with that. Can anybody identify what is this? Poppy field. So when the patients ask me that I want natural medication, I said you cannot have any more natural medicine than morphine. And if you look at it, this is how it is done. And really, that is how. So you can see the poppies. This is the flower. And can you see the bulb there? You dry the bulb, and inside it you find the granules, you crush it, and you eat it. That's morphine tablet for you. It does not go through much chemical interaction. Obviously, you need an alkaloid to make a tablet of it, and the right measurement and everything. But it is not worked, the active ingredient is not worked upon by anything. And they worked primarily to help different systems, and there are guidelines to prescribe it. So what the real answer here is, morphine is a good drug which acts on your body to help pain and some other symptoms as well. For example, chronic diarrhea or breathlessness. And it is also used for euphoria as well. This is how the intoxication happens. But the reality as a clinician for us is to assess the patient well, prescribe at the right dose, and we know that morphine causing death, if prescribed at the right level, is extremely low. We have not heard it. The last time the morphine prescribed by the coroner as written as a cause of death will be before my practicing days. We don't see that. Of course, if you want to give somebody intoxicating, give 100 milligram on the day one, they will die. So that's why you need good clinical guidance for it. I hope that clears that. So I'm just trying to go. These are some papers about good death, but we haven't got time to go through all that. So I will move on directly to the process of death and dying as prescribed in this country. So when the patient dies, we touched on it briefly, the patient dies home, hospital, community, care home, a death certificate needs to be issued, which is called MCCD, Medical Certificate for the Cause of Death. The system has changed recently in the last couple of years. So previously, a doctor wrote the death certificate, the family will take it to a registrar, register death, and then they can do the funeral. Now, there is another step in between. A doctor issues the death certificate, MCCD, which is then taken over to a medical examiner. And doctor does it himself. So I prescribe a medical MCCD and basically email that and the notes to the medical examiner, who by statute should contact the family within 24 hours to issue a death certificate. If the patient is a Muslim or a Jew, there is a box there which you need to click so that you can get the permission to do the funeral as soon as possible. And some of us who have been involved with Muslim funerals will remember a green form. So the green form could be done. But now what they are saying with this system, you can actually get a death certificate done before that even. But it hasn't materialized yet. So you still need a green form to get it. So you get MCCD, sent to medical examiner. So the point is, I think this patient died of cancer, but medical examiner will say, well, I've got a problem with that certificate. So I need to investigate a bit more. That's what they do. Their job is. So it has been taken out of the doctor's hands. Why? Because there have been some national scandals about doctors issuing death certificate which were exactly not correct. And then that certificate, the examiner will check it and then send it directly to the registrar, who does the 5-day time frame for registering the death. And then you can collect the certificate and go on. And again, as I said, if you're a Muslim or a Jew, you can request earlier than that certificate. But this is one of the steps our community needs to be aware of, which again, we need some systems in ourselves to either speed it up or be aware that the funeral will be delayed by a day or so. If you must have heard of the coroner, and this is another thing which causes a lot of grievance in our community. If a doctor is to say, I cannot issue a medical cause of death. In other words, it could be accidental, it can be unnatural cause of death, or I just don't see the patient. And in hospices, we very heavily encourage the doctor to stay involved so that, because the ruling is that the patient must be seen by a doctor in the last month of their life. Previously, it used to be 14 days. And if you haven't seen, we have to ask the coroner before we issue a certificate. So, the communities are encouraged to keep on talking to the doctor. They don't have to physically see the patient, but as long as they are involved in the care in the last month of life, they can issue a cause. Again, another delay, which is happening, and I have been involved in Muslim funerals where the doctor could not issue a certificate, it had to go to coroner, and they delayed the funeral by a week, almost. So we need to have system to support ourselves to avoid that. So I have just whisked through it, just to explain the challenges for the community.
Please, a question. And then we've got some really interesting questions on Slido, so we'll go to those, and then...
Sorry, Qamar was, I think then with the new regulation, the 28 days does not apply anymore. So the GP need to have seen the patient at any time in their life. So the 28 days is now gone.
Yeah, that is as a statute, it's gone.
Yeah.
But then the medical examiner asks the question, why did you not see it? And no, then you say, okay.
So the thing is, before the signing doctor should have seen
in 14 days.
Now 28 days. After COVID, it became 28 days. Yeah. Now anybody in the practice could have seen it, not the so if I've seen the patient 7 years ago, but a colleague of mine saw 28 days ago, I can still do the MCCD.
Yeah. Thank you. Sorry.
Thank you. That's excellent clarification. There's some questions I'm going to take from the Slido whilst everyone is ready. We have a few minutes for a few questions, then we're going to have a break straight away. So I'm just going to ask a few questions. Okay. Is it still wajib to give life-saving treatment if the patient, Muslim or non-Muslim, refuses treatment?
If the patient is refusing, you can't really force. So as a doctor, then you don't have a duty there.
Can I? Please. It will be battery. It will not be allowed by law.
Sure. Okay. Double no. Okay. If illness has...
Oh yeah. So
Isn't
they
it-
have made.
So minor, if it's an adult, sorry. So there is an exclusion to that. Minors and adults who lack capacity.
Yeah, absolutely. If illness has no cure, is it permissible to withhold treatment? Does this include CPR?
Well, if there is no cure, you can, as we said, we have the option of withholding but not withdrawing. We talked about it earlier. But when it comes to whether you can give the directive of, do not resuscitate, that one, according to Ayatollah Sistani, he doesn't allow that. I actually just sent a question this week. I was hoping to get the answer before this seminar, but I haven't received it, but on the same question.
Sure, of course. And as we have the palliative care champions, we can circulate relevant information at a later stage. Can a Muslim who has an incurable disease such as metastatic cancer sign a do not attempt CPR resuscitation even if resuscitation is likely to be unsuccessful due to their cancer? Same answer. Okay. Can you explain the difference between the role of the medical examiner and the coroner, please?
Okay. Medical examiner is a doctor who basically needs to agree with the cause of death written by the first doctor. Coroner can be a doctor, but they are legally trained people who look at unnatural deaths or where the cause of death is unexplained. So if a doctor knows what is the cause of death, it just goes to medical examiner, you get the certificate. If they are both not able to agree on a natural cause of death, it goes to coroner, who is a legally appointed person.
Thank you so much. I'm rattling through them, so the best way to get your questions answered, even I can see the hands, I'm going to continue with Slido, just to encourage Slido and lose my friendships. I'll come to you. A rule within a rule. We'll come back to. I know. Thank you so much. The question was: a participant mentioned a respect form. Can this be expanded on? And once Syed Rizvi is sort of more aware of this, are there potential Sharia pitfalls on this form for us to be aware of?
Respect is. How should I explain? So basically, it's a treatment escalation plan, which is completed by the healthcare professionals to say that in terms of this, like infection, patient should be treated, but should not be taken for hospital for IV antibiotics. So it basically gives an escalation plan. What is the most we can do for this treatment, for this patient in terms of treatments? And the second question was?
Within that, are there potential Sharia pitfalls on this form?
Okay. It falls into the same category as withholding and withdrawing treatments.
Fine. Okay. One more question from here, then I'm going to try to squeeze these in quickly, and then we can come to a break. What if the disease has a cure, but the cure has the potential to cause disability or lifelong suffering?
Then it is not a cure. And if it's not a cure, then it's not wajib.
So the cure would be an absolute cure.
An example would be, say, just to clarify on that, an example would be, for example, if someone's had a specific type of stroke, there is a specific treatment called thrombolysis for someone that's had an ischemic stroke. So someone that's had loss of blood flow to the brain, you can give a specific type of medication to help disrupt the clot that's resulted in that stroke. However, the risk is that it can cause major bleeding, which can inevitably cause neurological dysfunction where the patient loses control of all limbs. So, of course, the risk is, inevitable, significant disability, but the upshot is that it can resolve any disability as a consequence of the stroke that they've initially ensued. So that, just to give some context to that potential question.
Well, as a as a lay person looking at the issues not from a medical expert's point of view, I would consider that to be a bigger problem in a way. So from my Orfi point of view, I would say no, it's not wajib to continue.
Please, yeah, please.
So clinically speaking, what you are saying that there is a risk that it will cause. Use the word risk. Am I right? There's a risk. It's not a definite thing. So I think we will need to get the expert opinion on that. That based on this pre-existing disease, this age group, this type of a stroke, a CT scan showing that. Now, what is the risk ratio here? So if the risk ratio is more than the wellness ratio, then obviously we will have to have a discussion. Secondly, we should not be making these type of decisions by ourselves anyway. Any decision where there's the risk involved, and I'm called to the ITU type situations many times, where you need to have a multidisciplinary, multiple experts. Yeah. You still have got a consultant on call. Then you have got a neurosurgeon on call. So basically, this is why, like for example, I get the phone calls 2 o'clock in the morning from the ITU to say, should we go on ventilator or not? And the ITU consultant calls me. So I'm not going to say that, oh, I'm just sleeping and I'm not going to answer the question. You have got a right to, since especially after the Martha's Law, you have got the hospital has to make you available one more consultant to have a discussion.
The thrombolysis discussion is a tricky one because it's so time sensitive, as is today's agenda. That was a great segue. But in terms of, I think with that one, it's definitely a little bit more complex because obviously there's things to do with the patient and all of their factors, etc. Eligibility for thrombolysis, etc. Timing they've arrived. So there's so many quick decisions. I think this one is probably the hardest, trickiest kind of discussion. Maybe we take that one offline. We'll just go to Shabir and then inshallah we'll just have an actual break.
Thank you. I'm going to ask about DNA CPR. Sorry, I think I'm going to keep asking until I get the answer I want. So I'm still not comfortable because on one hand, what you're saying from a Sharia perspective is we're allowed to, as a Muslim, we're allowed to withhold treatment. So for example, life support. But under no circumstance are we allowed to withhold CPR. Now, when we do these advanced care planning that Professor was talking about, we have levels of treatment. So as a patient, you have the right to decide what at level do you want your treatment to be escalated if and when you become unwell. So the absolute lowest level is just treating curable diseases like an infection in your home setting. The next level is going to hospital and being treated. Then the next level above that is life support machine, and the level above that, which is the highest level of intervention, is CPR. But what you're saying, Syed, is that the Sharia are allowing to withhold life support, but not allowing to withhold the absolute highest level of intervention, which is CPR, which may lead to life support, because if that person survives CPR, there's a good chance if they have an incurable disease such as cancer, they will end up on life support. So to me, it seems conflicting.
I think I mentioned this issue that I still personally also have a challenge with this issue, but I can't issue fatwas. I might have an opinion, but it's not my place to give this opinion here. Otherwise, we'll have serious problems there. So, but as I said, I sent a couple of questions on these issues to Ayatollah Sistani's office. Inshallah, I was hoping to get the answer today. Especially one of them is on this issue.
Thank you.
So
Inshallah.
once we get it, maybe we'll circulate it through the group.
Okay. Because as the Jamaat representative, I think this is a question that's going to be asked, not just for me, but for anyone involved with palliative care.
Okay.
Fantastic. Thank you so much. I think we've really got to the a tough point, which is a great time for us to take a break and have some water and have some stretch our legs. And I'm going to ask if that's okay with you all. I'm to be back in maybe about 15 minutes, aiming for about 10 to, if that's okay. The other thing I would just ask is there are some QR codes on the desks. If you could scan them, provide some feedback, would be very appreciative so we can understand how we can improve things going forward. Thank you so much, and we'll take a break there.